Now moving on to our third section, that is the phalangeal joint dislocations and injuries. We will briefly discussing what are the interphalangeal joint dislocations, what is the pylon fractures of the middle phalanx, and how to deal with the condylar fractures and volar fracture dislocations of the phalangeal joints. Now coming to the interphalangeal joint dislocation, as you know, there are three phalanges on most of the fingers except for the thumb, which has proximal, the distal phalanx. This is the metacarpal. We have a proximal phalanx, and in between we have a proximal interphalangeal joint. Then is the middle phalanx, and then we have distal interphalangeal joint, and lastly we have the distal phalanx. Sometimes this proximal interphalangeal joints can get disrupted, although it's very rare to get a distal interphalangeal joint dislocation, which is very rare but can occur as well. Most commonly it is always between the proximal phalanx and the middle phalanx, and involves the proximal interphalangeal joint dislocation, which is more common. Although if it's a simple dislocation not associated with any fracture, the simple way is, if it's volarly displaced, you apply traction, displace it more volarly, and then extend it. But most commonly it is actually extended, going towards the dorsal surface, and is dislocated dorsally. So for that you have to just apply the traction under the anesthesia, and then further dislocate it in an extension, and then flex it to reduce back to normal position. Now joint has to be strapped to its neighbor for a few days, and why? Because body taping is required so that the joint can be immobilized. And usually for the other joints the movements can be begun immediately, but this joint can be kept immobilized for a few weeks at least. If you see over here, if this is the third finger, almost ring finger, and probably proximal interphalangeal joint dislocation is there, and this is the overlap. Although I cannot appreciate a fracture over here, if you see the oblique view, you can appreciate this is actually gone volarly, and the middle phalanx is actually present dorsally. On a true lateral view, you could appreciate it a much better way, that how much this has gone volarly and how much dorsally this is there. Therefore, if you want to reduce this kind of a fracture dislocation of the interphalangeal joint, then you have to apply traction in this direction first, hyperextend it so that it hyper dislocate it first, and then as this reaches over this point, as due to traction, then you flex this whole thing, the finger, so that this middle phalanx redislocates back into this position. If close reduction is successful, then the joint is stable. Then we have to go for the simple as an extension blocking splint. A temporary transarticular wire can be used as well, but it's only for a temporary measure till we can fibrosis occurs and the joint becomes stable. If it cannot be reduced and remains unstable, then a screw fixation, a transarticular wire can be used as well. Then once we reduce it back, we may have to go through a dorsal surface. You have to apply a K wire which goes through the metacarpal proximal phalanx as well as the middle phalanx, and causes so that the interphalangeal joint, which is the proximal interphalangeal joint, remains in place, and there is no movement of middle phalanx as compared to the proximal phalanx. And if there is very marked combination and instability, then you can go for a spring-loaded external fixator to distract the joint. Sometimes there is a fracture dislocation, and this area is so much combinated and unstable that you reduce it back, it will spring back out. So the best way is to just apply a small fixator, which is called as finger fixators, 2 pins over here and 1 pin over here and 1 pin over here, and reduce it back, and then we can use external fixator so that the proximal and middle phalanx remain in place where they were supposed to be, and let the combination heal over time. And over the periods, once the ligaments heal and fibrosis occurs, then we can recheck for the stability of the joint. Now coming to another term which is called as pylon fracture. Although it's more pathogenomically associated with distal tibia fractures, but pylon fractures do occur in the hand as well. And what are they? Head of the proximal phalanx impacts into the bone of the middle phalanx, causing the latter to splay open in several pieces. Now, if there is a fall on outside in such a way that the force is actually transmitted in this fashion. Now, if this is the proximal phalanx, its head is actually crashed into or jammed into the middle phalanx area. Now, this results in a comminuted fracture of the base of the middle phalanx. This is called as the pylon fracture. Usually common and very troublesome most of the time. Best treated by dynamic distraction using a spring-loaded external fixator. Why? Because most of the time it is a comminuted fracture. All you have to do is to apply a screw fixator, 2 pins of the proximal phalanx, one in across the joint into the middle and one into the distal phalanx, so that this joint can be held in normal position. It does not redislocates and does not resubluxes again and again. It usually rotates around the head of the proximal phalanx and disimpacts the distal fragment. But if there is only isolated single large piece, which is although rare but can happen as well, then that can be simply fixed with the use of a screw. As you can appreciate it over here, the fracture is first reduced. In the traction, the screw is actually applied so that this position is held in without any problem. Now coming to the condylar fractures. Now condylar fractures can be occur, as you know that usually the proximal phalanx also has the condyles as well, and these are actually this leads condylar fractures are actually due to injuries in which the metacarpal and the proximal phalanx get jammed into each other during the injury, leading to condylar fractures. Usually convex distal joint surface of phalanx gets fractured, and usually due to the angulated force. Open or both may condyles may be fractured. One usually can be most of the time it's the single condyle which is injured, because either the force will be abducting or adducting, but sometimes there is axial loading and leads to both condyle fractures. An X-ray after a week is used actually to ensure no displacement. If this is the fracture which comes in, and you can appreciate there is a definitely proximal phalanx condyle is involved over here, and this looks minimally displaced, but although it's minimally displaced, but still there's some degree of displacement is there. If there is undisplaced, we can simply use a splint or a thumb spica and get an X-ray after 1 week, so whether it has got displacement or not. If it has got displacement or there's even a minimal displacement, that means it's unstable and we go for K-wire fixation. But if there is no displacement at the end of the 1 week, that means although there is a condylar fracture, but it's stable, therefore it can be easily treated in form of a splint and in form of thumb spica. So as I told you, if the fragment is not displaced, disregard the fracture, strap the finger to its neighbor, or even apply, if it's involving the thumb, you cannot strap the thumb like this, so therefore the best way is to apply thumb spica or thumb cast. Other is concentrate on the regaining the movement first. But if it's involving the condyles of the, let's say, index and middle finger, we can simply use the buddy procedure as well. If the fracture is displaced and the risk of permanent angular deformity is there and loss of movement of the joint is possible as well, therefore what we do is we simply fix it, and fixing is through the closed reduction internal fixation as well, the use of K-wires, as you can be appreciated over here. But if despite this we are unable to reduce it properly due to any reason, because of ligaments getting caught in it or any tendon getting caught into this condylar area, therefore then we have to open it up, go for open reduction internal fixation, then open it up, reduce it back in place, apply K-wires, and then come out. The next is the volar flexure dislocation. If you see this over the side, this is the dorsal side, this is the volar side. This is resulting the proximal phalanx, the middle phalanx has gone more towards the volar side. This is why it is called as volar fracture dislocation. Relatively unusual, but it can happen as well. Why it is important? Because if you see on this extensor surfaces, this is a single slip of the extensor tendon attaches over here, and then the two slips go and attach over the dorsal interphalangeal joint. So if this extensor tendon gets injured, this can lead to a specific deformity called as paternal deformity, or if there's an attrition of the tendon or later on the tendon becomes avulsed, this can be very problematic for the patient. So this is important to reduce these fracture dislocation, although this is very rarely, but if they present, they usually require fixation. Central slip insertion into the back of the base of the middle phalanx is usually torn, and it has to be fixed because otherwise later on it will produce a paternal deformity, and usually often with the fragment of a bone. And you can appreciate over here is this is where the central slip is attached, and this is the bony chip which is actually has avulsed along with it. The best way is to go for, if the fragment is large enough, fixation with the small screw is undertaken, as can be appreciated in this post-op X-ray. If there is a tiny but displaced fragment, reattachment with the suture or loop or bone anchor is performed. Why it is reattached? You cannot take it out because the extensor tendon central slip is actually attached to this point. If no fracture or undisplaced fracture, then we can only go for splintage, and that again we can re-get an X-ray at 1 to 2 weeks. And why we need to get an X-ray? So that to see whether the bone fragment has displaced or not. If it gets displaced, then we may have to either go for screw fixation or resuturing of the small fragment. If it still remains undisplaced, we can continue with the extension splint for a few weeks till the tendon and the area heals and fibrosis occurs, and later on we can start range of the motion most of the time. So rehabilitation is meticulous to allow early range of motion, which is very important. And proximal interphalangeal joint is actually splinted straight for at least 4 weeks. If it involves a very small fragment which remains unstable and remains undisplaced, you can splint it for 4 weeks. Distal interphalangeal joint is moved actively and passively immediately, and even we can move the carpometacarpal joint as well. In this section, we will briefly go through the interphalangeal joint injuries, which could be in form of interphalangeal dislocation. There could be interphalangeal fracture dislocations as well, or this could be leading to pylon fractures of the middle phalanx, or could be the volar fractures of volar fracture dislocations of the middle phalanx as well. It is important to know that simple dislocation, whether it's interphalangeal, it's involving proximal interphalangeal joint and distal interphalangeal, the first and foremost is to reduce it closely under anesthesia. And if it remains stable, simple body tapping can be used. But if we are suspecting it to be unstable, or we suspected that it will get subluxed again, then we can use K-wires and use an extension splint for a few weeks so that the joint remains stable and it heals over time. Thank you very much. Keep watching sqadia.com.